Hello, everyone. Thank you very much for having me. And I want to thank Felicia for a wonderful talk. I'm just going to add on to that and introduce some cases. So without further ado, further upper airway conditions in children. I want to thank Dr. Marty Viche for having me and for the SAPA team. I have no disclosures. I work at Red Cross Children's Hospital. I'm the head of clinical services for otolaryngology. I'm also an associate professor at the University of Cape Town, and I have a very limited private practice at Netcare Christian Barnard Hospital in the city center. We do run a pediatric reconstructive airway unit. We look at complex ear, nose, and throat and airway conditions, and we do see a lot of neonates. We also do all types of reconstructive surgery, which is laryngotracheal reconstruction, as well as endolaryngeal and other open procedures. We are now in our 5th year of our pediatric ENT fellowship program. To give you a little bit of context, pediatric otolaryngology as a subspecialty actually extends beyond just tonsils and grommets. And it is quite a young subspecialty. It was established in the late 1970s with the evolution of airway management, especially since neonates were living a lot longer in the NICUs, and therein brought the entire generation of subglottic stenosis. And I like to refer to it as the revolution of airway management, because subglottic stenosis, I needed some sort of definitive intervention, and the expansion laryngotracheal reconstruction started in 1972 by Blair Ferron and Robin Cotton, and that's basically how we came into existence. So pediatric otolaryngologists basically see children with complex ENT conditions, like in this case, where a child with a huge cervicofacial tumor needed an airway and a definitive one at that. We also manage syndromic children with ENT conditions like these two below. And for the most part, regarding pediatric upper airway conditions, this is very common in children, even in the healthy ones. And it can be caused by various conditions. And it is actually extremely well managed by our pediatric colleagues. And only a really small percentage of children actually need to be referred to ENT surgeons for airway symptoms. So the big question is, what do we manage? And from your side, when do you need to refer a child with airway issues? To give a little bit of background and just to add to Felicia's talk, the airway basically has 3 main functions. And in specific importance, breathing is the main function. Swallowing and phonation shortly follow. Children present basically with upper airway obstruction as primary or secondary. They would present with stertor and stridor, dysphagia and aspiration, and dysphonia. If it was a secondary cause, what that implies is if the cause was taken away, the primary reason, the obstruction would be alleviated. So for example, if somebody had a tracheoesophageal fistula and every time they fed, they would have airway obstruction. If you stopped feeding them, the obstruction would be alleviated through that. How patients present basically, and what you need to look out for in breathing is upper airway noises. And what we know really commonly is stridor versus stertor, inspiratory versus expiratory and biphasic stridor, and the fact that the stridor is either fixed or variable. We want to know about obstruction with feeding, sleeping, on exertion versus baseline. So if you have stridor, when does it change? Does it change? And obstructive sleep apnea. For swallowing, we want to know if there's any difficulty feeding, choking, coughing with feeds, and if there's dysphagia with aspiration and velopharyngeal insufficiency. If a child has dysphonia, is it persistent or is it intermittent? Upper airway symptoms can present, as Felicia mentioned, from the front of the nose all the way down to the bifid trachea that enters into either lung through the carina. And then laryngeal conditions specifically, we look at the supraglottis, the glottis, the subglottis, and then the tracheal conditions that extend down to the carina. This is a wonderful picture, schematic picture from Philip Monnier, who is one of the earliest pediatric airway surgeons. And we know that laryngomalacia is the commonest condition. But what's not described here or included in this differential is papillomatous, which we see a lot of. And so I've added it in there. This is a very interesting graph because it shows that if a child is born at term, the first conditions that we see and the etiological factors that contribute to airway disease in 0 to 3 months is actually congenital. But if they're born premature or if they present to us after 3 months of age, it's usually acquired. So it's something that they've developed as they've come into this world, or it's something that has helped them stay alive, for example, intubation with subglottic stenosis. When we look at what specific history that guides us towards something that needs a referral to ENT, we want to know about the perinatal history, about the birth weight, prematurity, whether they were intubated, if they stayed for a long time in the NICU, and if they had feeding issues. In the general features to look out for is if they have a general failure to thrive, and if there's any congenital head and neck issues that you can see, pits and sinuses. Airway-specific queries are stridor and stertor, sleep disordered breathing, recurrent croup, especially when they need to be admitted to hospital because, it's refractory. And then a chronic cough, a nighttime cough, or a cough that wakes them up in the middle of the night. Any reflux or gurgling sound after feeding, choking, or aspirating. And specifically, when you look at stridor and stertor, the things to look out for, like we mentioned before about the variability of the symptom is it there at baseline? Is it there at rest? Is it there when feeding or sleeping or on exertion and exercise? This is a child who was born in shortly after birth, required an immediate airway intervention. You can see that the cords are mobile, but they are fixed. And this is a tiny posterior airway. Don't be fooled. There's a really dense subglottic stenosis below that. This is a child who's got DeGeorge syndrome and went on to airway reconstruction at a much later age. This child was diagnosed at birth, had a soft cry, biphasic stridor, and grade 3 subglottic stenosis. Grade 4 is complete occlusion. This is a child. I don't know if you can hear his crying, but he's got severe tracheal indrawing, intercostal recession, and he's actually got an ET tube in his nose, but that is giving him positive pressure. And he was failing to thrive. He was about 2 months of age, and he was actually diagnosed with a congenital bilateral vocal cord palsy. He came from home. This is a child who actually had an MRI, a fetal MRI, while mom was pregnant with her. And there were concerns at the time of the ultrasound. And as you can see, there's a huge head and neck mass, or rather a neck mass that's compressing her airway. And this is called the chaos baby, as Felicia mentioned, a congenital high airway obstructive syndrome. And this child actually needed what we call an exit, an ex-uterine intrapartum treatment, where the baby is half delivered and we intubate to stabilize the child and then deliver the rest of the child. As you can see, the actual tumor was 700 grams and the baby was actually not much bigger than that. So this is another exit. This is a child with laryngeal atresia, so complete fusion of the cords. If she was to be delivered, she would not have a chance. She would basically have 100% mortality. So we basically had her grow to 36 weeks, and we did a tracheostomy it's an operation on placental support, which means that the mum was the heart-lung machine until such time as we could form a definitive airway by tracheostomy. And once we managed to get the tracheostomy tube in, we clamped the cord and delivered her, and she's been fine. She's currently 5.5 years old now, and she's had her definitive reconstructive surgery. We're waiting to see how that goes at the end of this year. So again, looking at the pediatric population, it's something that we take very seriously, is that they're a vulnerable group of our population. And when we decide to do something surgical or intervene, we always consider the parents, we always consider their home environment. We also, think about the rest of their life. So is early treatment a good option versus waiting it out? And do we think about not intervening in the long-term sequelae for that, or for doing any intervention? The implications also of doing something, and whether they have some sort of knock-on effect on their development and growth. This is also something we take very seriously. So looking at how we evaluate the upper airways once you have referred a patient to us, we have a stepwise approach, so we don't miss anything. We are able to put all of the pieces together and make an assessment that is as accurate as possible. So we do a good clinical history and examination. We take into consideration the patient, the pathology, and the duration. We like to get some imaging, either chest x-ray or a lateral neck, or something that considers a directed investigation. And then our gold standard, and what's basically our armor, is our flexible nasal endoscopy. We do this awake because we see the upper airways as the child is breathing at baseline. And this is really important because we're able to determine what is going on at the level of the cords, above the cords, at the nose, between the entire nasopharynx, oropharynx, and laryngopharynx. We can pick up a vocal cord paresis, canal atresia, and vallecular cyst, and those things we can pretty much diagnose on that flexible scope. This, for example, is a child who came in with laryngomalacia symptoms, but actually was choking when commencing a soft diet. And as you can see on this image, in the area of the cricopharyngeus, there's a large hemangioma post-cricoid in that post-cricoid region, and together with that, laryngomalacia. The other tests we like to do is, if we're looking at specific airway pathology, multifactorial, multi-level, and also if we're considering doing some sort of intervention, then we do a direct laryngoscopy, tracheobronchoscopy, that's looking at the vocal cords above and below in the trachea, and we may decide to partner with our pediatric pulmonologist to do a flexible bronchoscopy. We also would consider doing a CT scan where we're worried about external compression, a vascular ring, vascular sling, and then when looking at feeding issues, a swallow, a milk scan, and sometimes an esophagoscopy with our GI colleagues. This is a 3D reconstruction of a child who presented with biphasic stridor, washing machine quality to the breathing. And here you can see that the trachea narrows in the cervical component and actually forms what we call a funnel-shaped appearance before widening again. This turned out to be a complete congenital tracheal stenosis, complete O-rings instead of C-shaped rings, and this child went on to have a slight tracheoplasty and basically is thriving 4 years later. This is another child who had complete tracheal rings. This is a very long segment stenosis, and as you can see, proximal to the stenosis is a very regular, straight formation of the airway, and that's because an endotracheal tube is in situ, and you can see that the left lung's completely collapsed, and this is because of compression of the left main bronchus. So this child also has a low-lying carina, and that's also a marker of some irregularity, and this child went on to be diagnosed with a pulmonary artery sling that basically wrapped around the trachea and was sitting between the trachea and the esophagus. And she went on to have a slight tracheoplasty pretty much immediately after diagnosis. So we assess the upper airway, and sometimes we need to take the patient to theater. We need to either make an assessment and definitively treat the obstruction, or we need to intubate. Sometimes it's very acute and we need more support, and so we do this in theater. We usually prefer that because it's a controlled setting, and sometimes when we do take to theater, once we have relieved an obstruction or fixed some sort of pathology, we can extubate in theater. We sometimes need to consider sending them to the ICU. But bearing in mind that children that we do take to theater often have a low functional reserve, they have a fragile airway, they're sometimes very difficult to intubate. And one pathology at the level of the cords can sometimes be 2 and 3. It's the subglottis and sometimes even in the trachea. So this is just some pictures of me in the operating room with one of my former colleagues, Fiona Kritzinger. And you can see the setup for the direct laryngoscopy on the left. And there's me with my telescope looking into the airway. And then on the right is Fiona doing a flexible bronchoscopy. So we do work quite closely in a multidisciplinary team. We need to work with people who understand the child. So we work very closely with pediatricians, with thoracic and cardiothoracic surgeons who help us with the cardiac and the thoracic interventions, especially when it comes to surgical decision-making, and then intensivists, tracheostomy nurses, pediatric surgeons, and our auxiliary staff. We also at Red Cross have a very consistent cohort of pathology. We have 10% supraglottic, 20% glottic, and then we see a lot of respiratory papillomatous. And for the most part, laryngotracheal stenosis keeps us busy. Our management options are basically aimed at providing a surgical intervention at whichever level of upper airway there is an obstruction from various causes. And our main aim really is to improve the function, the 3 functions that we mentioned at the beginning. Number 1, optimize breathing and alleviate the obstruction. 2, improve voice quality and address aspiration and feeding as number 3. So looking from the top down, if we looked at the nose, there's 2 distinct pathologies that sometimes get mixed up, but are actually quite different, and the treatment is quite different. On the left, you see an axial view of a CT scan showing a very narrow anterior or front part of the nose, where you have the piriform aperture that's stenosed. It's usually seen with single solitary incisor syndrome, and these children still grow. They may not need any intervention, but we monitor them for feeding and managing to gain weight. On the right is canal atresia, complete closure of the back of the nasal cavities. You need to create an immediate nasal airway. These children usually do not cope because they're obligate nasal breathers. They need an oral intubation, and they get transferred for recanalizing the back of the nose in order to establish nasal passages. So if we do intervene with piriform aperture stenosis, you can see we do a sublabial incision and we drill out the front of the nose. And these are pictures of the canal atresia that we historically used to basically puncture with urethral dilators. We're now a little bit more sophisticated, and we use an endoscope and make some flaps. And on the right is how it will eventually look. This is a child who is actually requiring nasal CPAP at birth and required it for at least 6 to 8 weeks. And she developed an acquired nasal stenosis with very, very narrow anterior nares that were really soft tissue. And Professor Lipper helped us to just create wider anterior cavities. And she basically presented with severe stertor. She couldn't feed. And once the passages were surgically widened, she thrived and didn't need anything more. This is the oropharynx, and if we talk about obstructive sleep apnea, you can see here on the left large lobulated tonsils. The tonsils are removed. You can see huge tonsillar cavities and resolution on the right. So if we had to spend a little bit of time on obstructive sleep apnea, for the most part, we always institute medical management, and there are a few studies that we use as a form of guidance and literature to provide medical therapy. So the Cochrane topical steroids review in children usually is given for moderate to severe adenoidal hypertrophy. We give intranasal steroids for 4 to 8 weeks. And this study showed that there was a remarkable improvement in nasal obstruction and the reduction in the size of the adenoid that was large when compared to the placebo. There's also a prospective observational studies looking at allergies and obesity and sinusitis that did not affect the results. So that's very helpful. And it usually is administered with an antihistamine. And if there is obstructive sleep apnea, we use Montelukast. So that triple therapy helps us determine whether shrinking the tissue will help alleviate the symptoms. It does not mean, however, that the patient will no longer require surgery, because there's a temporary effect to it. Touched a little bit on Montelukast, but there were multiple randomized controlled trials that showed a significant reduction in adenoidal size and improved symptoms. And while many people think it's an effective alternative to surgery, it may just, once basically coming off it, it may cause a rebound adenoid hypertrophy. And so one needs to consider whether it's a temporary measure or whether the patient still need a surgical intervention. If it resolves their obstruction and sleep disordered breathing, but they still just snore, then one can hold off on surgery. There's another study that was published at Red Cross, and actually this was performed by one of my registrars, and together with our pulmonology team, and in particular, Dr. Zampoli, we looked at overnight oximetry. And even though this was a well-established way to pick up severe and very severe OSAS, we then developed a stratification method for clinical OSAS, because, to be extremely honest, we struggle with theatre time and availability of operative slates for all of our children. And so we need to find a way that can stratify children in terms of severity, and that the most severe children get their surgery sooner than later. And so what we found in the study was that witnessed apnea by parents were 1.3 times more likely to have MOS 3s and 4s if there was a parental concern, if they needed to shake the child awake, and if the tonsil was more than a grade 2. These were also indicators or associated indicators with MOS 3 or 4. When looking at adenotonsillectomy in obesity, we know that the treatment, the surgical intervention to remove them actually improves, but does not resolve the OSAS in many of these obese children. And so we have to look at the additional therapeutic options. And often we need to do formal sleep studies, because we need to determine whether there's been an interval change post-surgery. So in summary, primarily for OSAS, you want clinical screening, You want to use an objective measure that is affordable. Where possible, you can use PSG, but otherwise overnight oximetry may be helpful. And we do recommend tonsillectomies for recurrent tonsillitis. We want to adhere to strict referrals, but rather refer to the ENT surgeon and let them make the decision on whether to proceed with an intervention if you consider the recurrence of the tonsillitis to be too many. We use Paradise criteria, which was really not very evidence-based, where it involves 6 episodes in 1 year. However, some kids can have one severe episode, and that may be enough to really require a tonsillectomy. And so we'll move on to laryngomalacia, which really is the commonest cause of stridor in children. We notice that it's soon after birth. There's a varying severity to it, and the management, for the most part, is conservative. This is really a wonderful picture because it shows the 3 classic findings for laryngomalacia in the atypical anatomy: an omega-shaped epiglottis, short area epiglottic folds, and bulky scissoring of the arytenoids. And so the stridor, as we mentioned, was inspiratory initially. It's variable. It kind of gets a little bit more dramatic or worsens when the child gets excited or feeds. The intensity and the frequency, however, does not imply severity. They usually present with feeding issues and some failure to thrive, some reflux, and they may also present with sleep apnea. This is a flexible nase endoscopy of a child who's actually got severe laryngomalacia. You can see on inspiratory phase of their breathing, there's an inspiratory indrawing. So every breath, the upper supraglottic component of the larynx closes in. This must be taken in consideration with other causes of stridor, like a vocal cord palsy, subglottic stenosis, webs and clefts, etc. And this is why the flexible nase endoscopy is so important while the child is awake. We know that more than 80% of them don't require intervention. The remaining 20%, however, will need medical therapy in order to assist with feeding and to guide regarding further interventions. And from this group, around 10% will require some sort of surgical intervention to manage their symptoms. If they present and they're just very severe and they're multifactorial and they've got many other issues and they're just not getting on top of their feeding, and they're very, very symptomatic from an airway, we recommend a tracheostomy and allow them to grow. But if they're moderate to severe, a supraglottoplasty can really be a game changer, and it's done to improve just the size of the laryngeal inlet. But now the main question is, which patients really require beyond just medical therapy? And if we have to look at from your side, which children really need referral to us and what are the factors that influence the need for surgical intervention? The surgical decision-making is quite crucial for us because it provides a good outcome, and it's minimally invasive surgery that actually can have a really good result. So children who fail to thrive, if they've got worsening persistent stridor despite being on medical therapy, they've had no change in their symptoms after commencing anti-reflux treatment, and actually if they're really severe, we try not to do surgery if we know it's not going to work. This is, for example, a video of the same patient from before. And then you can see on the right, this is a supraglottoplasty with a release of all of the indrawn tissue. Here's another picture and release of the area epiglottic folds. Automatically, you can see the vocal cords, whereas in the initial picture, you can't. This is a patient who required a rescue intubation. And as you can see, I'm releasing the area epiglottic fold on the right, and immediately the larynx just drops. And you can actually pretty much see a result at the time of surgery. And there you go. One must bear in mind that sometimes reflux disease is quite severe and it often accompanies laryngomalacia. It may be very closely related and may exacerbate the laryngomalacia symptoms. A laryngeal cleft is very rare, but it does cause communication between the larynx and the pharynx. And so they typically present with swallowing, choking, or aspiration. They often have chronic coughs at night. And really it depends on how extensive the cleft is found distally. You need a diagnostic workup, and we often start with symptomatic relief. And that really has to do with anti-reflux therapy, either medical or surgical. But the mainstay is really to make a diagnosis of how hard down it goes. And if it's above the vocal cords, usually we try and manage them conservatively. And if they do have risk for aspiration, then we do an endoscopic closure of the cleft. We may do an open closure if it extends below the true vocal cords, and or a combination if it's further down. We want to avoid a tracheostomy because we don't want to introduce more of a risk for infection or malacia in the trachea, and some kids may need prolonged feeding. So this is a picture on the left of a type 1 laryngeal cleft. It's splayed for visualization, and here in the middle you can see 2 sutures put to close the cleft, and then on the right, extreme right, is the healing that happens after 6 weeks. This is a very difficult condition to treat. It's called recurrent papillomatous. Everybody knows about this condition. You get persistent dysphonia. That's the first sign. In the developed world, that's what patients present with. However, in our setup with poor access to healthcare, patients present not only with dysphonia, which has a long history, but with progressive stridor and respiratory distress. And a lot of them present in extremis. And so you'll find that a lot of children actually need hands-on care every 3 to 4 weeks in the initial phase, and then it moves down to 3 to 4 months. But it really is a disease of the developing world, and I would encourage you to advocate to try and change the vaccination programs. This is one of our other patients where you can see removal of the papillomatous. This is a picture of us using coblation, and you can see that it's very gentle on the airway. We only remove what's obstructive. We try not to scar the healthy tissue. This is a patient who had severe obstructive laryngeal papillomatous. We actually thought she was going to demise because she kept coming in every 3 to 4 weeks. We gave her a tracheostomy, and we would have to actually enter the tracheal inlet of the stoma in order to basically debulk her. We gave her a trial of Gardasil as therapy. This was quite a few years ago now. She went into remission. We actually managed to get her decannulated, and she's been without papilloma since. So our vaccination therapy is really the key to preventing the next generation of papillomatosis. We really need to get going with our vaccination program that only covers for non-respiratory papillomatosis typing. And if you can lend your support to the rrpafrica.org. This is a child who came in with biphasic stridor, and she presented with dysphonia and basically had progressive stridor and respiratory distress. She wasn't really moving much air at this time. And so we had to take her to theater, rescue, intubate her. And this is what we found. Her entire epiglottis and her upper airway was quite abnormal, and it had pretty much been destroyed by some pathology. And you can see that she had irregularity on her chest x-ray and her upper airways as well. And so this is a video of her airway. Many people had assumed it was papillomatosis, but it just looked quite irregular. And so I removed what I could to establish an airway. We had to do a tracheostomy because the epiglottis and the surrounding tissue was so abnormal, and sent it for micro and histo, and it actually turned out to be TB of the larynx. This is a child with a saccular cyst. He had an inhalational burn, was subsequently intubated for a while, and when he went back for surgery to do plastic reconstruction on one of his digits, the anesthetic team found a huge saccular cyst, and you can see that this must have scared the hell out of them, and they referred him promptly to us. This is actually something that we were able to do a combined excision from endoscopically and open, and he's completely cured with no need for follow-up. This is a child who has a little sinus on his neck, as you can see on the left picture, and branchial sinuses can have a communication in the airway. And if you look at the video, you can see a little trickle of water just to the right of the uvula and behind the tonsil, and that's a branchial fistula because it communicates from the skin to the tonsil bed, and really just excising the fistula is cure. It actually is completely benign, and patients have it removed because they secrete mucus through that. This is literally a 6-week-old child who presented to hospital, who was previously healthy, but developed acute stridor while the mum was breastfeeding, and this was followed by a rapid neck swelling. You can see that it was actually something I could hold in my hand, and she went on to develop more severe airway obstruction. So we took her to theater, and the anesthetist gassed her down, and as soon as she gassed her down, the trachea deviated to the opposite side. I promptly intubated her, and as you can see on the right of her airway, in her right piriform sinus is a huge sinus, and that communicated with the big swelling in her neck. And so she recovered from that acute episode. We went on after a week or so and excised the cystic mass that was communicating with the airway. And on the right, you can see that sinus that we were able to open up and close. And she had a temporary vocal cord paresis. It recovered after 6 weeks, and she's been fine 5 years later, no issues. So tracheostomies are extremely important to take note of for patients who have a fixed airway obstruction, especially if they're born with an abnormal airway. And so the main aim is to alleviate the obstruction, either definitively or temporarily. And we can do a primary tracheostomy. And in essence, this bypasses the obstruction. This is, for example, a child who's 16-month-old and presented to one of our pediatric colleagues at Chris Barnard with acute respiratory decompensation and a bilateral pneumonia. She had basically restrictive lung disease and multiple fractures, and she was on a strict vegan diet, and so developed rickets, really. And she went on to require some support from an airway point of view. We had to do a tracheostomy. And once she was adequately supplemented and the rickets was treated, she had a full recovery, and we were able to decannulate her, and she went on to have a fairly regular life. So this child, unfortunately, I don't have pictures of her, had a cervical lymphatic malformation, and she presented to us at 3 years of age with severe OSAS. Her cervicofacial LVM was actually not resectable because it extended too far down into the mediastinum. We couldn't also do a tracheostomy through the LVM. So we consulted the pulmonologist, who then went on to do a sleep study, and she had severe OSAS. They started her on a BiPAP machine that she took home. And at the same time, we had applied for sirolimus or rapamycin as part of our vascular malformation team, and we started her on it. And after 6 months of being on therapy, she actually, the actual LVM shrunk to a point where she no longer needed the BiPAP. And you can see from the sleep study before, she had a MOS score of 4, and this went on to having basically no OSAS and not requiring the BiPAP at all. Those are pictures basically of MRIs that show just how the blue highlights show the multi-lobulated hyperintense lesion, and at the bottom how it just after it responded to therapy. I'm going to this is my last topic, is subglottic stenosis. It is, for me, one of my interests, and to give you some context, it's the most common disease requiring a tracheostomy in children under 1 year of age. It's usually acquired subglottic stenosis as the commonest laryngeal anomaly, and it is the congenital one is the commonest cause of congenital airway narrowing. And one can see that you can get then, therefore, a combination, either congenital, acquired, or mixed, and the risk factors are intubation. And I would like to add in the intubation injury, prolonged intubation, and poor sedation during intubation. All these things contribute to subglottic stenosis. Meconium aspiration and burns definitely add to that. Reflux disease and children who are intubated as neonates. Then the left is a video of a child who was intubated just for 2 weeks, and you can see the cartilage is exposed. On the right is a child I saw at 4 years of age who actually was intubated as a premature child and had biphasic stridor for 4 years. When I had a look at her airway, she had multiple little cysts in her subglottis, and she had this thick glottic band that was restricting her vocal cord movement. I released all of this, and she's actually had great vocal cord recovery and hasn't needed any more interventions. So when we look at subglottic stenosis, the management is either endoscopic, open, which is an expansion procedure, or a resection of the stenosis, or a combination. We often do a tracheostomy just to have laryngeal rest and then plan for definitive surgery later on. The choices of surgery really are dependent on the patient factors, the disease factors, and what you're able to provide in your surgical skill. This is a child who had developed acute stridor post-extubation, and if you wait for it, you'll see the video. She had subglottic swelling and a little bit of mucus that was really obstructing her at the time. This is a child who was intubated for acquired burns, for having acquired burns, and developed an acquired subglottic stenosis. And as you can see, there's a thin membranous stenosis just below the vocal cords, and actually was amenable to balloon dilation. And as you can see here, we use a non-occlusive balloon that is locally produced by Professor Darlene Leber. And what's really been amazing about this balloon is that we are able to ventilate this child while we dilate and provide therapy. And so children with low reserve are able to get definitive treatment. We don't need to abort the dilation, and we are able to continue with ventilation. So it's been a great addition to our endoscopic interventions. So once the balloon is out, as you can see, this is a really wide, beautiful stenosis, and this child never needed another dilation. This is a subglottic cyst. This is probably the biggest cyst I've seen from intubation injury. We were able to pop this, remove it, and de-roof it, and then dilate, and the patient had a great result. But this is also from intubation injury. These are cysts from intubation injury. We were able to basically decompress or de-roof, and in somewhere there's enough space, we are able to marsupialize them. So if we had to look at open airway reconstruction or laryngotracheal reconstruction, when we expand, we do laryngotracheoplasty. When we resect, we do criciotracheal resection. A single stage means that there's no tracheostomy to allow for healing, and a double stage means that we put a tracheostomy in and we put a stent proximally because we need to give more support to the laryngeal framework. You can cut the back of the cricoid and you can cut the front of the cricoid. You can do them both at one time, and you put cartilage into position. This is a 6-year-old girl who had a tracheostomy and was managed at another hospital. Mum had changed her home and was now part of a community that drained into Red Cross. And she presented one day with a history of a foreign body in the airway. And if you look at that chest X-ray, you can see in the left main bronchus, there is a tracheostomy tube as well as a tracheostomy tube in the original position. So the tracheostomy tube broke off in the middle of the night and she replaced it. And as you can see on the right, if I played this video, you can see the subglottic stenosis that I dilated in order to access the tracheostomy tube. And below that, you can see the tracheostomy that had been broken off that was sitting in the left main bronchus. We were able to retrieve it thanks to the cardiothoracic team. But because she had the subglottic stenosis at birth, she was actually intubated for a prolonged period of time, was extubated, and there basically was some downtime, and she had a tracheostomy then inserted. So she was actually a child who had who was HIV positive, was a high-functioning cerebral palsy child, and the subglottic stenosis developed at birth. Her social circumstances were very poor, and her tracheostomy care was clearly not good. She had a committed single mom, and I thought, well, let's get her up to a position where we can get the trachea out. Let's do reconstructive surgery to a subglottic stenosis, and we can improve just her general function. So this was the subglottic stenosis that she had. We needed to do an anterior and a posterior cricoid split. We used costocartilage graft. We harvested that and we placed it down. And this is what she looked like before we decannulated her. Beautiful wide airway. She was talking well. She was able to breathe sufficiently, and we decannulated her. She now is a walker. She's a high-functioning CP, and she even goes to school. So laryngotracheoplasty, careful patient selection, high volume centers really do a lot. And so it's better to keep them in high volume centers. You want to have someone do these reconstructions who does it all the time. It is definitive treatment for severe subglottic stenosis, and you do need the skill set, and you need really good perioperative care, especially in the ICU and for maintenance if they do get restenosis and things like that. Complete congenital rings are, as we mentioned before, children who have O rings instead of C-shaped rings. This is a child who had a hypoplastic right lung, a pulmonary artery sling, and a long segment tracheal stenosis. As you can see here, he had O-rings from the second tracheal ring, and that was all the way down to his carina. And this is him at the time of the slide tracheoplasty. We cut the stenosis in half, and you have a proximal component that's stenosed and a distal component that's stenosed. And then we incise it and sleeve the top end into the bottom end. So we create twice the diameter of what was there before. And this is really done with the expertise of the cardiothoracic surgeons who are very skilled in suturing really small airways in small vessels. And so this is done on bypass. And as you can see here, this is a single suture that goes all the way around, and you have literally the trachea in two halves. So this child, after 6 weeks, was looking really good. And you can see that his airway is reconstructed. He's got twice the size, and you can still see some of the sutures as well. This was a child we did a couple of weeks ago. I worked together with a really experienced cardiothoracic team, and this child was 6 weeks old and had presented to us with airway obstruction and had a really long segment of tracheal stenosis. As you can see in the picture, this is the child on bypass. It's a 1 millimeter diameter. And like I mentioned before, we cut the stenosis through the center and we sleeve the top end into the bottom end to create twice the diameter. This is done on bypass, and it's done basically with the expertise of the cardiothoracic surgeons. And we do this as a collaborative combination of surgical expertise. So, and finally, this is my last slide, your take-home message. And I hope that this is something that this talk is something that you've gained from. And so these are just a few things I want you to take home. Understand the differences between stertor and stridor, because it helps guide why and how, why you send patients to us and what you would like us to manage. It is really important to have a basic understanding of the upper airway functions. Always remember the ex-premature child. Always remember the previously intubated child. Be very cautious of syndromic children who have anatomical variabilities. Physiological upper airway obstruction is not uncommon in them. Be wary of children with laryngomalacia that persists after 2 years, and they can still have symptoms and are still amenable to surgical intervention. Please, please promote the HPV vaccination therapy that covers RRP. And then these symptoms shouldn't persist. So you shouldn't have an interrupted sleep or obstructive symptoms. You shouldn't be choking and gagging on food. There should never be dysphonia. And children with variable stridor, on exertion, on anxiety or sleep really need to be investigated. So thank you very much for bearing with me. I hope you've gained a lot with this talk, and you are welcome to contact me for any cases with airway issues that you're concerned about or that need some sort of airway intervention. Thank you very much. In conclusion, airway conditions that need referral are not common. When in doubt, as I've mentioned, refer to an ENT surgeon specialist. And if you're still a little bit concerned, but you're not sure someone needs surgery, refer to pediatric pulmonology. So thank you very much. And thank you for having me.